Morning. I'm so pleased to be able to speak to you today about pediatric anesthesia for the pediatrician. I think the most important disclosure for my talk today is that I was a primary care pediatrician who knew very little about anesthesia. And in my first few years in practice, I admit that many times I said to the family, well, I think you might need ear tubes, but I'm worried about the anesthesia, so let's wait for a day, or let's wait for a few months and see what happens. And I think that, so this talk, later on I changed my life and went back and did more training and another residency and fellowship. And so this talk really comes out of what I think pediatricians should know about anesthesia so that you can appropriately answer your family's questions, so that you can advocate for your child who might be getting ready to go for an anesthetic, and that you can appropriately weigh the risk. When do you think it's time to refer the patient to a specialist that might require surgery? So what we're going to talk about today is what is the real risk of anesthesia for your patient that you send to the operating room so that you can answer those kind of questions for your parents. What should a parent be present for induction of anesthesia? And then what do we do for the child who comes for anesthesia who's sick, or the child comes to your pre-op visit who's sick? When can they eat? What are the MPO guidelines that are recommended by the Society of Pediatric Anesthesia and what we do here at Children's? And then there's some hodgepodge information that I couldn't figure out how to put into one group, but I thought was really important for pediatricians. So what is the real risk of a child? Take the scenario that I just mentioned earlier. If you're sending a generally healthy child for ear tubes, what's the real risk of anesthesia? Well, I think before you talk about the risk, you really sort of need to understand the nomenclature of the American Society of Anesthesia. We classify patients based on their pre-comorbidities coming into the operating room. So an ASA1 is a healthy patient. An ASA2 is a patient who has a single condition, not a risk to life. So that might be a patient who has asthma or who's coming in with a cold, a patient who has some other kind of like single isolated, a single isolated but not a major deal illness, major deal disease process. 3, 4, and 5, you can see, tend to increase the degree of complexity, and you'll see in a minute, increase the risk of anesthesia. So if you look at the ASA 1 and 2 patients, which is going to be the predominance of patients that you send for anesthesia, patients who either have no health problems or have a little bit of asthma or a little bit of like single problem, if you look at those patients, the risk of death, which is what your patients are worried about, right? What if we overdose on anesthesia? Is one of a very common question I get asked from parents, is exceedingly low. So looking at the literature, the Pediatric Perioperative Cardiac Arrest Registry, which is a voluntary registry of approximately 80 institutions in the United States that does thousands and thousands of anesthetics. Looking at the most recent report, so the last 10-year period, there were only 5 deaths of children in the ASA 1 and 2 group. Now, I liked the data before, like between the 1997 and the 2004 report, I was able to say to people, there are no deaths reported in healthy children having anesthesia. Unfortunately, 5 happened in the last report, but this number is still exceedingly low. And to put it into even more perspective, the pediatric risk of death, this is perioperative death, not just anesthetic death, but any death, is somewhere around 1 in 10,000. You can see that in the middle category there. I don't have a pointer for you. Oops. And that is about in the range of the risk of dying in any accident at home in the next year. And then what is the risk of having a cardiac arrest? So not death, but just having a serious event requiring chest compressions. Well, children are much greater than adults. I mean, there's no question that anesthesia in children is riskier than anesthesia in a healthy adult. The risk of perioperative cardiac arrest in children is somewhere around 3 to 5 per 10,000, whereas the adult risk is about 1/3 of that. However, if you'll note, the risk of needing emergency treatment in the next year after being injured by a car, a can, a bottle, or a jar is 10 times greater. So I think that perspective-wise, when I consent parents, I usually say to them, the risk driving here was significantly greater than it was in what we're going to do in the next 15 minutes. But no one asks you to sign consent to drive on the Beltway. So I think that it's important to put that risk into perspective. And then what are things that really do increase risk? Wheezing definitely increased risks of perioperative anesthetic complications, specifically pneumonia or bronchospasm under anesthesia. So if you have a patient that has asthma, I think your risk discussion or your risk counseling to them might be a little bit different. If the patient has a URI with symptoms present, we try not to do those patients, and I'll talk about how we deal with URIs in a minute, but that does increase the risk. And then I'll just note that having a family member who smokes increases the risk of perioperative anesthetic complications for your patients. This is an opportunity for you to, again, re-counsel your families that stopping smoking is a good thing all around. And then who really has risk? The most significant risk for children undergoing anesthesia are those less than 1 year of age, so infants. If they have an ASA 3 to 5, remember those are patients with life-threatening illness going into anesthesia. If they have cardiac disease or like this little baby is a preterm infant. And then if they're an emergency surgery. So even if you're an ASA 1, if you come in as a 1E, that 10 times increases your risk of associated problems. So I think the message here is that sending a patient who has minimal health problems for a straightforward surgery has an exceedingly low risk of anesthesia or surgical problems. And that's something that you can safely say to your families. So can I be with her when she goes to sleep? So let's say that this is actually a very controversial area in pediatric anesthesia, and at meetings, national meetings like this, pediatric anesthesiologists sit around and debate whether or not parents should be present for induction. The practice throughout the country and even in this area varies, but I think and so counseling your parents about that is a little bit challenging. The literature does not support that having a parent present at induction reduces the patient's anxiety. And there's a really terrific study, I hope that you can see this well. I think the best study that looks at parental presence during induction of anesthesia was out of Yale, and they did a randomized control trial where they had 4 different groups. The top group is a control where an anesthesiologist could do whatever they wanted, parent present, not parent present, give the patient an oral pre-med such as oral midazolam. Another group had parent presence in the operating room, so parents came right back with them and stood there while we put the mask on, and then the patient went to sleep. They had something called the advanced group. That was their intervention group. And these patients had preoperative teaching about what's going to happen when you go into the operating room. They taught the parents distraction techniques for when they're waiting in the waiting room to help the child. They did a surprise bag of goodies, things to pull out while we were working on, and taught the anesthesiologist distraction techniques as well. And then they had the midazolam group, which is where you got an oral pre-med and then just went back with the anesthesiologist without the parent. And what I've circled in red here is the parent, and what they measured is child anxiety by a visual anxiety scale. And what you see here is that the parental presence had significantly more anxiety than either the oral pre-med or the advanced group. And interestingly, in the advanced group, the patients who had advanced prep before anesthesia, induction of anesthesia, those groups received something like 1/3 of the amount of midazolam and 1/2 of the amount of fentanyl needed for the surgery. They were half as likely to have postoperative delirium or emergence problems in the PACU. So this was a group that came into the experience with significantly less anxiety, carried that through their operative, and then their anesthetic experience was much better. So this is a very highly quoted study to say that what kids really need is not their parents in the operating room, but advanced training. And this was ages 2 to 12. So what do we do about that at Children's? We have a pre-op prep visit for children who are undergoing anesthesia that happens every Sunday at 2 p.m. where families can go, they get a tour, the kids get to see what they're going to do, and they play with the mask, and they get a little coloring book. And this has been going on for greater than 45 years. My sister-in-law remembers her pre-op visit for her tonsillectomy, and she's 45 years old. We have slides on our website for parents who can't come for their pre-op visit. We do have child life specialists who are present day of surgery to help distract the parents for children who maybe weren't able to come to the Sunday visit or had sort of a more urgent surgery. And then we also provide safe zones in our pre-op area. No physician exam or pre-med or any kind of interventions in our playroom areas. They only get those in our other areas. And so the next question is, so what do we actually do about parents being present in the operating room at Children's? And the answer is, it's significantly, I think in the way, it depends. I think in the way that real life never reflects the neatness of any literature anesthetic, or literature in the, any information presented in the literature. I think it just depends on really on the anesthesiologist, the surgery, and what the child needs. In our outpatient centers in Rockville and Virginia, nearly all of the parents go back for those. At the main hospital, we have induction rooms. That's a picture of one of our induction rooms there, where we'll have parents come for the induction room, parents leave, and we move off into the operating room. So we don't actually take parents into the operating room theater at Children's. And then we sometimes do oral midazolam, depending on how the child looks, and then sometimes we do nothing and we just all walk back together. And I think, so the answer is, I think when you are presented with this question, will I be able to be with them? What you can say is, I don't know, because the practice really varies. However, it's really important if you're able to take your child for a pre-op tour and visit. That will make a big difference. You can talk to the anesthesiologist when you go. If you're having outpatient surgery at one of the outpatient centers, you can say probably you'll get to go back. Mostly they do there. But I think encouraging your parents to do preoperative education and discuss with the children what's going to happen, and using safe words. We have safe words listed on our website, things that they can discuss so that they can answer questions about anesthesia would be really helpful. So then, what's the question? How long does he have to go without food? Now, I'm sure that you know that the most common answer is everybody says MPO after midnight, and that's an adult recommendation. That's not a really child-focused recommendation. And there was a Cochrane database review that looked at all of the literature around when can children eat, or what's the risk of aspiration and then pneumonia associated with how long they eat. And what we've discovered is, just like in your practice, is that breast milk has a pretty rapid transit time. And so infants who are breastfeeding can have breast milk up to 4 hours prior to surgery. So that means if they're scheduled for 7 a.m., they can have breast milk till 3 a.m. If they're scheduled at 10 a.m., they can have breast milk till 6 a.m. And we allow clears up until 2 a.m. We have a sort of more liberal policy in the under 1-year-olds than the greater than 1-year-olds because the greater than 1-year-olds can go a little bit longer, and we do like to have a little bit of flexibility when they arrive at the hospital if, in the unusual circumstance, our room is going early. I hate to have a patient sit waiting because they ate exactly at 4 hours, they had their clears exactly 2 hours ago, and it's 1.5 hours, so I can't really take them back. So we do this is the guidelines in terms of this is exactly what it is. If 2 hours is the minimum time I have to wait, we like them to have a little bit longer. So when they come for their pre-op visit, they'll talk about that. We like them to have a little bit longer for scheduling purposes, not for safety purposes. So these are the guidelines that we use. So in terms of when you see a patient, when we ask you to see a patient or a surgeon asks you to see a patient for a pre-op evaluation, what kind of things are important there? So, because I was always sort of struggle with this. Give me this paper, and I have this totally healthy kid sitting in front of me, and I'm like, yeah, the kid was healthy just like he was when I examined him 2 months ago and asked you to see him because I thought he needed surgery. So the things that are really important are things that are going to increase risk. So if the child has any comorbidities at all, if they come into the surgery or the anesthetic with a associated problem, they're going to have an increased risk. If they have asthma, we ask you to activate their sick day care 3 days prior to their surgery, and I'll talk about that in a minute again. If they have obstructive sleep apnea, that actually increases risk of postoperative apnea, and many of those kids will either, if they're very young, ask for a sleep study before, or sometimes just ask them to spend the night for observation in the hospital before. If they come in with the URI, the guidelines for URI used to be that if you had to be 6 weeks out of a viral infection in order to reduce risk of anesthesia. That was just crazy. I see you all laughing. 6 weeks, right? Like, because they'll just have another URI. So what we have now, the recommendations are currently, because of new literature that shows the risk declines pretty rapidly at 2 weeks asymptomatic. So we like you to be about 2 weeks without symptoms, although the reality is if a child comes in with a little runny nose and is close to 2 weeks out or has minor symptoms, we'll usually do them anyway. And then the question I think to really ask yourself is this patient optimized for surgery? Is this the best that we can do? Is there anything else I can do to make them better as they go into this surgery? And is this the right surgery for the patient at the right time? I think you as the pediatrician need to agree that we're all going to jump into this pool together. So what do we do to help manage risk for patients? We have a preoperative care clinic that is an anesthesia and hospitalist, so a pediatrician and anesthesia co-service that screens all of our patients who are having surgery. All surgical patients receive a pre-op phone call and teaching a week before and then the day before to sort of like rediscuss the MPO guidelines, to see if they have any issues, to remind them what time to come. And then we see and evaluate in person patients who are having complex patients, so patients who usually are about an ASA 3 or greater, so if they have some kind of illness that is a risk to life, or if they're having a complex surgery, and I'll just highlight right there because here's one you're going to see a lot, patients who are having posterior spinal fusion. So idiopathic spines are patients that we like to see in the pre-op clinic, although they technically come in as an ASA 1, usually they're healthy because it's a big surgery that has a lot of pain post-operatively. We like to get them ready for that. Sometimes the patients want to pre-donate blood. We want to arrange that for them. So those patients we like to see and sort of help them. We see any patient who's referred by the surgeon or the pediatrician or is picked up on our screening that needs to be seen. And I gave you both the email and the phone number, because if you have a question, your patient is coming in for surgery, even if they're not somebody who would necessarily be seen in the preoperative care clinic, but you'd want to talk to the anesthesiologist. I have a specific question about what to do with this medication. I have a question about, what do you think I should do to manage this issue? My child's having surgery in 2 weeks. What do you think we should do? You can always talk or email. You can call the POC clinic and talk to an anesthesiologist or email us, and we'd be glad to help you with that issue. And this is an example of, you're not supposed to be able to read this, but just to show you, this is the preoperative care order set or list for patients who have diabetes. So a patient who's having diabetes, who has surgery, type 1 diabetes, would come into the preoperative clinic and has a whole list of things that we do 2 weeks before and the day of to kind of manage them, to get them safely through their anesthetic. So here are some things that will definitely cancel your surgery. So if the mom calls your office and says, my child has fever and we're scheduled for surgery tomorrow, you can tell them just to call us and we're probably going to cancel that surgery. Obviously vomiting and diarrhea, that one's easy. Wheezing is sort of a big deal for us anesthetically. It significantly increases the risk of perioperative laryngospasm and bronchospasm, which is our #1 cause of problems in anesthetic problems in children. It also increases the risk of pneumonia, so we sort of take that seriously. If the patient's having an active wheezing episode and we'd like to cancel the surgery. If they have RSV or pneumonia documented in your chart within the last 4 to 6 weeks, we will defer surgery if possible. Now that's different. Remember, you all laughed when we talked about URIs and we said, oh, everybody has a URI. But if it's RSV or pneumonia, that puts them into a different class of risk in terms of perioperative problems, and we like to wait those. Again, I mentioned the URI guidelines is 2 weeks. And then NPO violations, which we have very little of, thanks to our pre-op calls the day before, we will cancel for that. Here's some other practical information that I just couldn't figure out where else to put for you. That children under 8 who you send in for an MRI or CT will probably be receiving anesthesia. that those children generally can't hold still for those. And so if you are sending in a patient, if you think the child needs an MRI for something, and you think it can wait, and i.e. if they're 4 months old, if they can wait till they're 9 months old, those kind of things are going to getting closer to 1 is going to decrease their anesthetic risk, counseling the parents that they will probably need anesthesia in order to get those studies done. Routine medications are often helpful day of surgery. So if the patient is on their ADHD meds, it's not really fun to anesthetize a kid who's anxious off their ADHD meds. If they routinely take Valium for their spasms, I'd really love them to take their Valium. If they take pain medicine, I want them to take their pain medicine. I want them to come in as good as they can be. So the MPO guidelines do not apply to medications. Now, if they take their medications in applesauce, we have to sort of work on that. But if they can take their medications with a sip of water, that makes our job much better. And no anesthesiologist is going to cancel a surgery for medicines with a sip of water day of surgery. We prefer it. If their gestational age is less than 52 weeks, i.e. if they were a preemie and they were born at 33 weeks and now they're 7 weeks old, that makes their gestational age 40 weeks, that child needs an overnight stay for their anesthetic. So because they have a significant increased risk for apnea and problems following their anesthesia, we generally try not to do elective surgery. So, no hernia repairs, no circumcisions on kids less than 52 weeks for this reason. But just so you know that if they're preemie or if they're under 52 weeks, they're going to have to spend the night for observation. And I mentioned the sick day plan. If you have a child who's wheezed 3 times in the last year and they're coming in for surgery, we like you to institute your sick day plan 3 days pre-op. So if you put them on Pulmicort or if you use albuterol or whatever, we like them to use them 3 days before and day of surgery. And feel free to call the POC Center if you want to discuss that or help you with that. And I mentioned the POC Center again right there. I think I'll just take a moment to mention that I think being a pediatric anesthesiologist, different than the concept of anesthesiologist that I had when I was in medical school and even residency, anesthesiologists are really pediatric advocates and innovators. Virginia Apcar, I'm sure that you know, was a pediatric anesthesiologist who felt that it was important to be able to assess the babies in the delivery room. And then I have also pictured Dr. Harmel, who was the pediatric anesthesiologist who worked with Alfred Blaylock doing the first BT shunt, despite the fact that everyone told him don't do it. It's not a good idea. We deal with the same children that you do every day, trying to figure out how to get a child with autism to agree to put the mask on to go to sleep, how to get the child who's bigger than me with trisomy 21 to get through this, and helping the parents. We, just like you, use all of our creativity and interpersonal skills to help the patients and the families get through a really stressful situation. So we really want to be your partner in the care of your patient in the perioperative period. We take your place in the operating room and work as the pediatrician to advocate for the child and help them get through. This is what this is all about, like seeing the children go from really sick to really healthy. And if there are any questions, I would be happy to take them. Please make sure that you keep the POC information because that's a really great resource to speak to an anesthesiologist on the fly at any time. Thank you.
So if you have questions, let's use the microphones because we're recording this, please. And we actually have 5 minutes for discussion.
Okay.
So
I was a little early.
I
forgot to start my timer, so.
That's okay. We are starting and finishing surgery right on time.
Anesthesiologists are nothing but precise.
But this is actually, so all those pediatric anesthesia questions, tee them up. This is the time.
Hi. Quick question, hopefully, about tube anesthesia for simple, short operations. Tubes, common things, tonsils and adenoids. What are the medications, and are the same things followed for that as opposed to major surgery?
Sure. So of course, tonsils, adenoids, and ear tubes would be the most common surgeries that we do. Just a minute about technique, because I think it's also really important to give you a perspective about the ear tube surgery. So surgery for ear tubes, the child comes into the operating room, we put the mask on and they fall off to sleep. As soon as they're asleep, we turn our head to the side, the surgeon puts the ear tube on the one side, we turn our head to the other side, the surgeon puts the ear tube on the other side. We sometimes give a little bit of intranasal fentanyl to help them with wake up. We take the mask off. It's about 7 minutes of anesthesia. And I think that that's really important because that is the surgery that made me think about this talk, because that's the one I'm sort of deferring sending my kid who's struggling with their ear infections because I'm worried about the risk of anesthesia. We don't even put an IV in for ear tubes. So it's a quick, easy, and very safe procedure. Oh, what's the gas? Oh, thanks. So the gas is sevoflurane. It's an anesthetic gas that is breathed into the lungs. It's picked up by the blood and travels to the brain. It puts the brain to sleep in ways that we don't entirely understand. And then when you take the mask off, just by diffusing, goes back to the blood and breathes out. No metabolism. So. And it's gone in about, the kids are asleep in about 30 seconds, and then you take it off and they're awake in about a minute. So it's a very quick and easy, no IV surgery. Tonsils and adenoids, so the medications they'll get is sevoflurane and then a little bit of fentanyl just to help them wake up, and with a little bit of pain. Tonsils and adenoids are a bigger deal surgery because there's a significant amount of pain associated with that. The children get a mask, go to sleep, they get an IV, because they need IV pain medication and nausea medication. We do put a breathing tube, we endotracheal intubate for that. The surgeons do their thing. We give pain medication, anti-nausea medication, and lots of fluids through the IV because you know how they are immediately post-tonsils, nobody wants to drink. And then when they're done, we take the breathing tube out and we go back to the recovery room. That procedure is about a 20-minute procedure. So those are our most common anesthetics and the most common things. And so the patients will almost always receive some kind of anesthetic gas and a pain medication. And then if you're doing tonsils, anything bigger than ear tubes is going to get an anti-nausea medication too. Okay. Yes?
I recently had a 16-month-old who had an adenoidectomy and PE tubes, the offspring of 2 health professionals.
We love those.
At about 7 days post-op, just continued to have, really escalating behavioral meltdowns, separation issues. The father did a little research, looked up midazolam and kind of this post-anesthesia, kind of syndrome. Can you comment a little on that? And I talked to an anesthesiologist, Aaron Zuckerberg, who said we see it rarely in kids, and it usually just
goes away,
peters out, but maybe some antihistamines are helpful. Do you see that commonly, or?
It's very rare. It's very rare. And so what she's referring to is there's some thought that young children have some kind of post-anesthesia syndrome where they have persistent behavioral disorder, sleeping disturbances, and it sounds like your patient had separation issues after anesthesia. I will say that we see it very, very rarely, and I will say that there is something about the preschool children who have anesthesia in the, particularly the 2 to 3 age group when they come in. I think part of it is because there really is no way to prepare this kid. I mean, there's no way to tell a 2-year-old or a 16-month-old exactly what's going to happen to them. So they come in and they get a mask and go to sleep, and then launch into this complete unknown. So maybe or maybe not they're cooperative with their mask. They wake up, they have, especially if they've had adenoids, they have a lot of pain, they have nausea, you know how awful you feel after anesthesia, and there's just no way to prep them. Additionally, a very short anesthetics, so tonsils, adenoids, ear tubes, actually are at increased risk for emergence, meaning emergence delirium. Patients wake up, it's just inconsolable, screaming and crying, and it's very disconcerting to parents. But it goes away in about 15 minutes or so, but those age kids are the worst for it. And so just in my experience, I sort of believe that there is something about the child that you can't prepare, that they don't know what's going to happen, and then they feel so awful and it sort of snowballs into this thing. That's why I do think pre-op discussion is really important for any age that is old enough for it.
Yes. We can work through these next 2 real fast. No, and then we'll move on. That's fine.
A little long-winded, yes.
Tom, or if you keep it short, it's fine.
I'll try to be faster.
Yeah.
Can you comment on something that was circulating on the internet about pediatric anesthesia and a risk for neurologic problems or developmental delay or something like that?
Yeah, neurotoxicity. So the quick answer is there's nothing known in children. It's all in rats. And so, so as long as we're not anesthetizing rats, we think it's okay. It's also important to note that, like, you cannot have surgery without anesthesia. We do everything we can and follow the literature closely to protect the children in terms of not using neurotoxic drugs. We only use the amount of anesthetic we need, not more. But the short answer, we get this all the time, and it's only so far in animals, and we use the best experience and literature that we have. Yes?
I have a very similar question, but I think I read something saying that there was an increased incidence of learning disabilities in kids who'd gotten anesthesia in infancy.
Not familiar with that. I am not familiar with that literature. So I can look at it. If you want to give me your information, I can look it up and get back to you.
Okay.
Mm-hmm. All right. I think we did get to the end then. We have...
Most of the time we get requests for the pre-op about 2 weeks in advance of the surgery.
Mm-hmm.
And by the time the surgery comes up, that's where the clinic comes in, looking for the cold, looking for everything else. The other thing is when you have the 3 to 5 patients, the kids who have hypoplastic left heart and all of that, we see them, it makes them feel comfortable. What else can we do?
Yeah. So for the ASA 3 to 5 kids, I think I would send them to the POC clinic if you can. Counsel them that, that they want to have a good discussion with their anesthesiologist, that they want to feel comfortable. And really, I think, even though I admit I've been a pediatrician where I'm signing these forms thinking, why do they care what I think? It's like, this child looks fine. It really is helpful to the parent for you to be a participant and a part of the whole process, and for you to, like, hold their hand and say, you know what, this is going to be okay. Feel free to call the anesthesiologist. We'll be glad to talk with you and sort of continue that communication. But I think that having the pediatrician as part of the perioperative team is really critical. All right, thank you very much for your time.